Good morning. We want to start our meeting. I know in the registration form it was indicated we are starting at 10 a.m. But that was a very big error we made when we were creating the link. But we are trying to mobilize people, so we are expecting other members will be joining us as we continue. So our presenter, Dr. Wachira, will be joining us at 10 because he had another meeting scheduled for this time. So meanwhile, we can do a case discussion. Then as we wait for our presenter to do the presentation. So maybe we can have someone pray for us so that we get started. Lillian, Tiara, you can pray for us, please, if you can hear me clearly. Tiara? Okay, maybe we are not. So Ilda Onyango, you can pray for us. I can see your mic is unmute.
So, shall we pray? Hello.
Yes, go ahead.
Merciful Father, we want to pray, Father, this morning that you may intervene into our meeting as we are starting off, Father. We bless your name, Father, this morning. May you, Father, cover us with the blood of Jesus. We pray that may give us a sound mind, Father, and understanding in the midst of us as we are discussing issues pertaining, Father, our people, of our country, Father. Bless our leaders, Father, our President of the Republic of Kenya, our doctors, Father, who are taking care of all people, Father, who are suffering, Father, and who are in need. In Jesus' mighty name I pray.
Amen.
Amen.
Thank you, Hilda. So maybe we can hear from Floria before we continue. I can see your hand is up. Okay.
Sorry, it's by mistake. Sorry, let me remove it.
Okay. So what we'll do, because there was that mistake in terms of setting up the link for the meeting, you will allow me to start the meeting with case discussions. And we have this case we discussed last month in our meeting. And one of the recommendations was to do a DST for the case. It was a male patient who was failing that line regimen. We did the feedback very early enough. We were able to get the DST result back within, I think, 2 weeks. So I will share the case maybe to jog our mind a little bit so that we understand what we are dealing with. Then I will share the DST result. But before we go there, I will invite our Casco. I can see he's on the call. Kiplagat, maybe you can say hi to the team and open the forum for us.
So thank you, Chris. Good morning, all. As you've heard, my name is Kiplagat Anthony, and I support HIV unit at Nairobi Metropolitan Services. I want to take this opportunity to thank the organizers and the participants for joining this our monthly call on issues relating to HIV and how we can support cases at our facilities and manage our clients. But also it's a platform for just to update ourselves and get the updates in terms of management of our clients on various other conditions. I know Chris has clearly admitted that there was an error in setting up in terms of date, but we can assure the team that Dr. Wachira will be joining us from 10 just to discuss on the issues of TB latency. I know currently as facilities we are facing issues of stock out on isoniazid, and people are wondering now what is the next step. So it will be important for us just to understand when you talk about TB latency, and any other findings around that, so that it can also enlighten our knowledge. So I don't want to take much of our time. We can be meanwhile mobilizing our members, but also discuss the case so that we do not waste a lot of time, so that when it reaches 10, we can start, the CME can also pick up. So I just welcome you all, and back to Chris, and thank you, Chris.
Thank you, Kiplagat. So I will share the case. I can see the team from EDAP are present in the meeting. So I will just go through the case. Then we will discuss the DST result. Maybe probably by that time, before we finish this, we'll have gotten our presenter for today. That is Dr. Wachira. So let me share the case. Also, Mweni, who is our the head of the communicable diseases unit, division of communicable diseases in NMS. She promised to join the meeting. Probably she'll join at 10. So when she's able to join us, we'll allow her to say hi to the team. Okay. So this is a case we discussed last meeting. It was a client who is failing his third line, which was started in 2018. So I'll just go with I'll just do a quick summary of the case so that we are able to understand what is happening with our client. So this RK is a male, 38 years old, who has been on ART for the past 9 years. RK was initiated on TLE regimen in November 2011. Our patient also has history of hepatotoxicity, which necessitated 2 months treatment interruption of first-line medication, that is TDF, 3-TCF due to high level of ALT. He was treated for TB adenitis in March 2013 and completed the 6 months treatment. In October 2013, he was switched to second-line regimen of AZT 3-TC lopinavir due to virological treatment failure. The patient was able to achieve viral suppression 1 year after switch to a second-line ART regimen. At 2 years on second line, he developed low-level viremia of 441 copies. That is in December 2015, after which he developed high viremia that continued to rise with time. Our patient was followed by the facility MDT due to viremia while on second-line treatment between January 2017 and January 2019. During this time, it was noted that the client had relatively good adherence as per self-report and pill count. PHQ-9 assessment score was at 0 in January 2019. The patient was supported with virtual dots between October 2018 to January 2020. Home visit done in August 2018 demonstrated correct pill balance. He also received 12 sessions of EACs with no major adherence gaps identified. However, a history of long-term proton pump inhibitor used and antacid use in 2017 for 2 months was noted as possible contributor to treatment failure. While failing second line ART, the patient was also enrolled on community adherence support by CSO in Majengo, that is ILFA Kenya, and the organization supported the client to receive a DST test. And this DST test we discussed during the last meeting, and it demonstrated high level resistance to both lopinavir and atazanavir with low level resistance to darunavir. High level resistance to AZT, nevirapine 3-TC, FTC, and ABC. 1 minute, please. Just 1 minute. Give me Sorry for that. So I'll continue. So we have seen there was high level resistance to AZT, nevirapine, 3TC, FTC, and ABC. There was also intermediate resistance to efavirenz, low level resistance to TDF and RPV. So the patient was switched to that line regimen based on above DST result, and well, the team settled on TLD. And that is DTG regimen, which after 3 months of switch, the client suppressed. That is in April 2019. And the viral load now started to rise again to 43,000 copies. That is in September 2020. The delay in viral load monitoring in 2020 was due to COVID-19 precautions, patient work schedule, and lockdown in Isili, where the facility is located. During this period, that is between April to September, the patient was reached virtually. There was support, 7 contact at least once every month, during which he reported good adherence. Patient was resumed on MDT follow-up in October 2020 after his viral load in September was high at 43,975 copies. When informed of high viral load, he reported no significant changes to his adherence, social or work environment. He reported using alarm reminders at 10 p.m. as before. He has no sexual partner, no history of alcohol consumption. The MDT team recommended resumption of virtual dot by his treatment supported, that is via the healthcare worker. So referral also was made to clinical psychologists. So the actions are post MDT, there was virtual dot, which commenced in October 2020. There was a typing error, and it is still ongoing. Clinical psychologists review was done. So there were 2 sessions with the clinical psychologists, whereby the client had no psychopathology based on screening, including PHQ-9. He is insistent on his adherence during and before virtual dot. Strongly believed drug resistance to be cause of his rising viral load. However, patient was noted to be defensive and evading discussion perceived to suggest gaps in adherence. He did raise the issue of stem plant treatment and believes this could be viable treatment plan for him, despite being informed that this is an experimental study. The clinical psychologists plan to continue engaging in motivational counseling. So we go to family and social history. RK is a single, lives alone, and reports not being in any intimate relationship. He works for parastatal and often works in shifts. He reported disclosure of status to his mother and 2 cousins. Unfortunately, all lives outside Nairobi. Previous attempts at eliciting sexual contact have been unsuccessful, and he is generally guarded with his sexual history, despite having close relationship with his healthcare workers. That was a very good summary for this case. Then when you look, maybe you can go through the table, just a snapshot of it. You can see the client was started on ARVs in the year 2011, that is TLE. And when you go down, you can see there was improvement in terms of, sorry for that. I wanted to show you the improvement on the CD4. So the CD4 baseline was 40. It went to 105. After 1 year, that is in November 2012, there was an improvement of 174 cells of CD4. Then it went down again in 2013. That is just 2 years after starting ARVs, to 40. Then also weight was going down, and this is the time now the patient developed TB. You can see client was started on TB treatment. Then the switch from TDF 3TC efavirenz was done after from TDF 3TC efavirenz to AZT 3TC lopinavir was done after treatment of the TB treatment, meaning there was no drug interaction concerns that moment. So we can see after that, our client weight started going up. Then the viral load, we got LDL at one time, that is in 2014. Then we got a low level viremia. Then from there, we started getting high level of viremia. So you can see the progress, but weight was still going high and high. So the decision was made in 2018 to switch this client from SNT3TC lopinavir to TLD, and this was based on a DST which was done in the same year, that is 2018. Then from there we can see our client started suppressed. We end a viral load of 23 copies. Then again, we started getting issues with the viral load. So this is the viral load which was done in this year, January. So when we discuss this case, we end several recommendations. I will share the recommendations. I don't want to go through the whole case because of time, and this is a case we already know about. I was just reminding us what we are dealing with. So I think the issue here is more of when you look at the likely root cause of poor adherence, is more of the sexual history is not clear. We don't know if this client is an MSM, if this client has multiple sexual partners. We are not sure if the client is currently abstaining from sexual activities. So that is a gap which was noted. Then you can see the dots, the facility are doing dots. The enhanced adherence counseling is also continuing, and also the incorporation of clinical psychologists. So I will just share what we recommended from the last meeting. So when you look at these minutes, these were the recommendations when we discussed this case in the last meeting. So the recommendation was that treatment supporters of this client, that is the mother and the cousins, lives outside Nairobi. So we thought it's wise for this client to have a treatment supporter or treatment buddy who lives around Nairobi. Then we advise the facility to explore more on the history, sexual history, because that is a gap, because we don't know if this client is an MSM. Does this client have multiple sexual partners? Does this client use condoms? So we need to know that. So we also recommended the continuation of DOTS. We also recommended we discussed the outcome of the DST result with the clients, so that you can fully understand what is happening with this treatment. Meaning, if you fail that line, what are the options left for him, so that if we are able to convince him in that line, he can be able to open up more and understand what is happening with him. Then we need also to continue the psychologist and nutritionist review. You can see the client has a weight of 115 kgs. So we need to incorporate the nutritionists to help in the issue of obesity. Then close monitoring of this client with short appointment. This is a deadline, a patient filling deadline. It's a very critical case. So it's not a client you want to give long appointments. Then DST was recommended, and we were also to include the INSTI sequencing. Remember, this client is on INSTI-based regimen. Then we continued adherence monitoring dots with the current regimen. So until we get DST back, that is what we have been doing. So once DST results are back, we share with the TWG, and that is why we are here today. So this is a client who has failed his first line, his second line, and his third line in just 9 years. Remember, we have clients who have been on care and treatment for the last 20 years. and they are still on first line. What is happening with our client? Why is our client failing his medication within a short period of 9 years? So I think we can go through unless there are any concern, and if you have any concern, please feel free to type in the chat. Maybe before I share the DST, we can hear from anyone from ADAP, St. Vincent, so that we see if whatever we recommended has been done. Then I can share the DST with you. So maybe Vera, are you able have you been able to connect your, yes, Vera.
Yeah, good morning, Chris and everyone. Hope you can hear me.
Yes, I can hear you.
Yeah, sorry, I had a few challenges with my sound on this end, but now that has been rectified. So I would like to respond to the recommendations that you had made in the last meeting. So in terms of treatment supporter, the patient is not yet ready to disclose to any other person who lives around here. He's only comfortable with his mom and his two cousins, whom we had noted that they live out of Nairobi. So the healthcare provider, that is me, I've been his treatment buddy since even before he was switched to third line. So we are continuing. And for the dots that were recommended, we are continuing with that. We are doing 10 p.m. dots, which he's been on time throughout. About exploring his sexual history, he reports currently not to be sexually active. And as we had noted earlier, the client had, he has a 6-year-old daughter, and I think they separated with the partner back then. He reported it to have been a one-night stand, and that's how the baby came about. And so he's not in any other relationship, any other sexual relationship. About the nutritionist follow-up, our nutritionist is, we are giving lifestyle counseling for this client. He's enrolled into a gym. He's trying to work on his weight, and the nutritionist is also doing a monthly follow-up. For the shorter refills, the appointments, we are doing monthly refills for this client. Remember, he's also on TLD, and we're also facing shortage in, we have stock out in TLD. So we are trying to make sure that we're giving shorter refill, that is monthly on our end. I hope I've responded to all the recommendations that were given in the last meeting. Unless I've missed out on anything, Chris, kindly point it out so that I can respond. Over and back to you.
Okay, thank you, Vera. I think you have responded to all the issues. Unless any member from the team has a question for you, maybe they can type on the chat, or they can just unmute and point it out. So that was our case for the last meeting. So I will share the DST results. So this is the DST result, which was done on 15th February 2021. That is 3 weeks ago. So when in NHRL, whenever, okay, I can see there's something from the chart. Okay, so maybe as I discuss this DST result, maybe you can answer, Vera, you can answer Dr. Karanja, who is administering the 10 p.m. dots. Okay, maybe Vera will respond to that.
Hello?
Yes,
sorry,
yes,
sorry
Vera.
about that, Chris. Let me respond. Okay, I'm the one who does it. I'm his treatment supporter, and we do WhatsApp every 10 p.m. in the night. So sometimes we do WhatsApp calls, video calls. Sometimes he sends me a message, and I check on him. That's how we are doing the dots.
Okay.
And I remember I had mentioned that he does a night shift sometimes. So at that time he does text messages, but when he's in the house, he does the video calls.
Thank you, Vera, for that. Yeah, okay. So that is dot, which is done by healthcare worker virtually. So as I continue with the discussing the DST, so whenever we send a case or a sample to NHRL, they always do viral load before they sequence for drug resistance. So when they did viral load, it was that 3,792 copies per ml. Remember, if you send a sample to NHRL and it's below 400 copies, they do not do the sequencing. So they will just send back the results that the client suppressed. So you continue with the current regimen. So okay, we'll check the charts. So this is what we got from NHRL. So the results were released on 26th February this year. So this is our clients. So drug resistant database, we can go straight to the PIs. So when you check at the PIs, you can see we have atazanavir with intermediate resistance. Then darunavir, we had a low level resistance. Then fonsaprenavir, we end high level resistance. Idinavir, we end high level resistance. Lopinavir, we end high level resistance. Then neltinavir, we end high level resistance. Then saquinavir, that was intermediate resistance. And lastly, on PIs, we have tipranavir, which end intermediate resistance. So when if you can recall the DST, which was done in 2018, atazanavir and high level resistance. So I talked to NHRL to try and understand why there is a discrepancy or there is difference between what we got in 2018 and 2020. The explanation is that when you are sequencing maybe a class in which the patient is not on currently, you get some errors because of when you're trying to they use some lab terms, but basically what they meant is that there are no blood levels of these drugs for that client at that level because the client is on TLD. He is no longer on the PIs. So that was the reason. But basically, whatever is here can be of use when you're trying to formulate another regimen. Maybe I'm clear on that. Or if anyone can put it better than I have, maybe you can feel free. So that is the PIs. So we go to this class of INSTI, the integrase inhibitors. So when you look at DTG, which the client is on, there is high level resistance. And when you look at this bictegravir, we have high level resistance. Basically, all the INSTI have high level resistance. Okay. Then we go to this class of NRTIs. NRTIs, we have abacavir, as the dovodine, stavudine, or with high level resistance. Then we have high level resistance on both the FTC and 3TC. But tenofovir has maintained from the one we did in 2018. Still, it earned low level resistance. And this one has low level resistance. When you look at NNRTIs, we have doravirine, which has low level resistance, efavirenz with high level resistance, then etravirine with potential low level resistance. We have nevirapine with high level resistance, and lipivirine with low level resistance. So when you look at this DST, there is one thing which came out clearly. Actually, I never expected this. I expected to have maybe resistant mutations on TDF or Dadunavir, but it has surprised us that this client is actually filling the INST medication. So I don't know what the take for this case, what the regimen for our client, or if there is anyone with a concern on the DST, maybe you can try and ask before we formulate the regimen. Anyone with a question concerning the DST results? If there is any concern, maybe you can type on the chat. So I'll go through the chat. So if then if you think there is a certain regimen combination that will work for this client, please just type it on the chat. Yes, Dr. Eunice.
Okay, so good morning, everyone.
Morning, Doc.
Chris, you said you wanted an explanation why we were not getting a true picture of the PIs.
Yes, yes.
Remember the theory of archived mutations?
Yes.
So for us to get a good, clear picture of current mutations and resistance patterns, a client should either be on the same drug that we are targeting or should not be off the drug for more than 4 weeks. If the patient is on the drug for more than off the drug for more than 4 weeks,
yes,
then there is a tendency that the mutations that were there that time are archived. And so you may get a picture of sensitivity of the drug. But when you give the patient that drug, then the mutant virus that was already archived can relapse. So that is why I think you're getting a picture. Previously, we had high level resistance to ATVR and lopinavir. But since the patient has been off the drug for more than 4 weeks, then that is why we are getting a current picture showing us like atazanavir would be sensitive. So just at the back of our minds, we should remember about the archived resistance and archived mutations, so that we don't make a mistake of thinking that now the patient can be sensitive to either atazanavir or lopinavir. So the other thing I have seen is that the patient is also currently now resisting DTG.
yes, yes.
Yeah, and that is why I was raising the concern of, we have seen patients who really can be difficult. And I think to Vera, she has done a very good job of even going ahead to even take her time. Because I'm imagining 10 p.m., Vera probably, most of that time she should be home with her family, but is going out of her way to do dots and to have video calls and chats and WhatsApps with this patient. But sometimes we can only do so much for clients. So I don't know. I really would wish that I don't know. I'm not sure. Probably he swallows. And when Vera does not remind him, he avoids to. I don't know. Because Vera also mentioned something about night shift. So we are not sure whether he takes it consistently or he only takes it to do when Vera is watching. I don't know. The other thing we should address for this patient is why the patient is taking the medication. I think what is the goal for the patient to take his medication? Because I'm seeing a dependency kind of case here where he's taking quote to please the healthcare worker who is following him up, other than taking the medicine for his own benefit. I don't know. I think I'm a bit confused, but let's look at the case together with a very open mind. But I think the team from EDAP has done a good job, but resisting DTG in such a short while, I think says quite a lot about the adherence.
Okay, thank you for that, Doc. So maybe anything, Vera, to add on that?
Okay, thanks, Chris. Thanks, Daktari, for raising those concerns. So for this patient, these dots, we've done them since last year when we realized that he's failing his third line. So when he's doing his night shift, what he does is he texts me at 10 o'clock that after he's taken his medication. And it's quite evident on my WhatsApp chats. He does that on every single day, be it on a weekend, be it on a weekday, he does that. But when he's at home, we do the video call. So, I mean, that's when I'm saying that I might not be really sure if he's taken his medication at that 10 o'clock when he texts me. But we have had very intense discussions with this patient, and he really understands that, you know what, we really have very minimal options left for us, and we need to take our medication. So in terms of him trying to please me, I don't think that is the case, because he really understands that he needs to take his medication for his own good. Then I don't know if I missed out on anything. You said okay, for me, I was just thinking, would it be that this patient got a strain from the beginning? I mean, just because when you look at his treatment, we only had an interruption for about 2 months. That was when he was on TLE. And then thereafter, the patient has been adherent. But probably in between, maybe history of alcohol consumption, on and off, because he said he used to occasionally take alcohol. But all these issues were addressed. So we are now at that point, just wondering what next.
Okay.
Over and back to Chris. Yeah.
Thank you. Let's hear from Javan. Then Javan Olang.
Okay, thank you very much, Antitrust. Yeah, Javan Olang. Antitrust, very question. I don't know whether she's the only person who is doing the dot or there's somebody who is assisting in case of maybe the client has traveled or herself she's busy. I felt if you can get somebody who assists her, it would be better in a position whereby Vera sometimes can actually get from the treatment supporter, because most of our clients, they tend to please, just as we have said earlier. So if you can get another person who can assist Vera, that would be better. It was just an additional point.
Thank you, Javan, for that. Okay. Anyone else? I can read through the charts before we formulate a regimen for this client. So there was a comment from Eunice Karanja, but she has explained that about the archive mutations. Then yes, I can see someone want to. Yes, Adro Mutuku, please go ahead. Yes, Doc. Okay. So you can read through the chat as they prepare to give their suggestions. So from Kibanda, he also concurred with Dr. Eunice about the archived mutations, which can really disorient a clinician. So that's why we are very careful whatever we formulate here. Then it seems there are motivation issues arising from patients. The team at INDAP has gone out of their way. Yeah, very true. Then we have another from John. The clients claim to have good adherence, whereas the DST result says otherwise. The client needs to be honest and say what is really happening. We are likely to go to a fourth line, but the story will remain the same. There is need for a peer to work with him, and probably he will open up. So the fourth line selection will be a TDF, 3TC, Darunavir, even though all of them have low-level mutations. So that is from John. Then we have a Floria. Let's try TDF, 3TC, Darunavir for these clients. Adherence is an issue for this client. Something is not coming out clear from the client. My concern also, what is it with the, that might be, because is there maybe an aspect of transferred mutations, or what we call transmittent resistant for this client. I don't know. So we have gotten the two options. Actually, two participants have given a similar option for this client. Anyone else? Okay, so we have Kibanda TDF3TC darunavir would be an option. Could there be infection with complex recurrent types of primary infection? Maybe you can get that from the team. So we have TDF3TC darunavir that is coming out very clearly. Maybe this also will help in trying to maintain the pill burden for this client, because TDF3TC is an OD drug. Then darunavir, I understand, can be given either OD or BD, depending on many factors. So we will see whatever works for the client. Any other any other option? So maybe because of because all the regimen for these clients have either low level, high level, or intermediate resistance. Can we rely on any NRTI like etraverin for this client, which has potential low level resistance? Yes, Caris. John, just unmute and speak. So I'm still concerned about because the regimen we are giving is TDF, 3TC, and darunavir. All these have either low level or high level resistance. We understand for TLD, for 3TC, it's okay because of producing the unfit viruses. What about now the TDF, which is low level, and darunavir? Do we need to boost with another, maybe from an NRTI, or we just maintain that? I don't know. So John?
Yes, Chris.
Yes.
I wanted to say that as we consider this regiment, that we consider the strength of the drug more than the pill burden, because we may just end up reducing the pill burden and land on this forum again.
Okay.
Yes.
So do you suggest we add another maybe molecule?
We add another to make it a little bit, even though they are not all somehow fully working.
Yeah.
We have a combination to make it a little bit more stronger.
Okay.
Yes.
Which one do you suggest?
Not yet.
Okay, just think about it. So maybe you can add another molecule so that we have at least a good combination for this client. Remember, we did the same mistake in 2018. We gave TLD without boosting with another molecule, and now we are here again. So John? Yes, John? Okay. So maybe we can make use of the charts. Let me check the chat. Okay, let me read from Eunice. So since they are I sincerely think that at this level we have no best regimen for this client. We have nothing 100% sensitive. So we may have to go with TLD and darunavir. So TLD and darunavir, I don't know how many are agreeing with that. So we also, from John, we consider etraverin. So I don't know, do we go with TLD plus and darunavir, or would we put etraverin in the mix? Because remember, DTG is causing, we are suspecting, yeah, because it is not confirmed yet, that the weight gain is due to due to DTG. Do we need to give a client a drug which will keep adding the weight? And that drug is actually not working. I don't know. Maybe you can hear, maybe Dr. can explain the rationale behind that. Doc, maybe you can try and explain why do we need to get the DTG back, and it's already high level resistance. I don't know. Dr. Eunice? Okay, yes, Wilfred. Wilfred, I can see your hand is up. You can just
Yes, good morning, everyone.
Morning.
I think we should, I support what Carissa said, that we don't actually give a weak regimen in this case. I'm considering TDF 3TC, darunavir, plus maybe an NTI, which will make the regimen more stronger for this particular client.
So which one is in your mind, Wilfred?
A traveling.
A traveling.
Yeah.
Okay, thank you. So
I think that one will make the regimen more stronger for this particular client.
Okay, thank you for that, Wilfred. Thank you. So we have these options. We have TDF 3TC, TDF 3TC, and darunavir. Then yes, John, just go ahead. John?
Yes, Chris.
Yes.
I don't know. I still have some reservation on having four drugs. If we add a traveling there, though it has low level resistance, and I think there's this issue with adherence with this client. Are we not going to complicate more if we give 4 drugs? I don't know how will be the dosage with it. Will it be once per day, or it to be it will be, of course, it will be separate dosage. Yes. Are we not going to complicate the adherence more? And looking at all these drugs, which we can be able to select their low level resistance. I wish we could have at least one drug, maybe in the NNRTI, that is susceptible. That one is probably a consideration we can have, so that we can boost the strength of the regimen. But even giving a traveling there, it will still be a low level resistance. But again, the concern is usually it's on the appearance part.
Okay. So what do you suggest, John?
I think my option, as I typed, is TDF 3TC darunavir.
Okay, thank you for that. So far we have three different options. Maybe we can hear from Dennis.
Good morning, everyone.
Yes, morning, Dennis.
Mine is really just a concern, even if as we try to make the regimen strong, that we consider the various molecules we are using. Although nothing stands out to me in terms of interactions, I think it is also important to consider any potential interactions and maybe any variations that we will need to do in terms of dosing. I don't have anything stand out to me right now, but that is probably something we would consider doing in an intensive way.
Okay, thank you, Dennis, for that contribution. Okay, so we have 3 options here. We have TDF 3TC darunavir without a traveling. Then we have TDF 3TC darunavir plus a traveling. Then we have the TLD plus darunavir. So I don't know which one do we go with, because we only have 8 minutes to wind up on this case. So I don't know if we can have maybe a second opinion. Yes, Aska, please. Okay, Aska, maybe for just a mistake. So maybe we can work with the three. We can work with the three regiments. If it's a complex case, then I can discuss with the National Clinical Support Center. That is the NASCOP level. Then we can come up with the arrangement for this client. I don't know if you agree with that. So the last viral load was let me answer Dr. for that. So the last viral load was done actually on the day they did the DST, and it was should be 33,792 copies. Okay, well, so doc, that is the latest viral load we have. That was done on 15th of February. So my suggestion was that I go with the three options, then I discuss with the National Clinical Support Center at NASCOP. Then we come up with the arrangement for this client, if you allow me as the team. Okay, so John Mutuko is agreeing with my proposal to consult the National TWG. So maybe you can work with that so that we save on time. But I'm happy we have really participated to try and support this team from EDAP, St. Vincent. You know, this is not an easy case. Actually, that is why we brought this case in this forum. So maybe to inform the team, nowadays we are no longer bringing all the cases in this forum. So we agreed with the stakeholders in the units or in the division that we can actually have a forum, TWG forums within sub-counties to be discussing cases at the sub-county level, so that we don't rely only on this forum, which only meets once in a month, so that we capitalize on our resources and our professionals who are very experienced in matters HIV. So we came up with the 6 TWGs, which will be sitting at least 8 TWG at the sub-county level will be sitting at least once a month. And when they sit, they discuss cases emanating from that same sub-county. So like on Friday last week, we had a TWG meeting, a case discussion meeting for Starehe, Mathare sub-county, whereby we discussed 3 cases. On Friday, on Monday, the next week, we'll be having Langata Kibra TWG sitting to discuss another 3 cases just from the sub-county. Probably that week, depending on the work shift of the members, we will maybe schedule another meeting for maybe another sub-county. So the cases we'll be bringing to this big forum is those cases, those complex cases like this one with a lot of learning points, or those cases with maybe a patient with multiple comorbidities and their drug interactions concerned, so that the team can learn from that. So that's maybe that announcement we didn't make early, but that is what is happening for ground. Maybe I can read through the chat. We still have 4 minutes before we welcome Dr. Wachira to take us through the CME of the day. So John was asking why, okay, so Floria also said it's okay, we can consult the national TWG. So John was asking why DTG, and it has high level resistance. And I also agreed to consult on the regimen. So maybe we read on what Dr. Karanja has explained. So that 3,000 is quite high. Not sure if we have both mutant and wild type of virus. So since DTG and darunavir have high resistant barriers, a mix of the two would probably subdue the virus supported by the M184V from the 3TC resistance. So maybe it's an option we can give when we are doing the discussion with the national team. I will inform you during our next meeting on the regimen we will agree on, and of course the explanation behind that. So Vera, thank you team for the support. So maybe if we have Dr. Wachira from CHS. Before that, do we have Elizabeth Mweni from NMS? Can say hi to the team. She had promised to join in during the meeting. Maybe if she's on call, she can say hi to the team. Yes, yes, Mweni.
It's my first time.
We can't hear you. We can't hear you clearly, Doc.
Can you hear me now?
Yes, yes.
Hello, can you hear me?
Yes, we can hear you now.
Oh, sorry. I say I take this opportunity to. Okay, thank you so much for inviting me. I think I'm learning a lot on the HIV world, on the drug resistant, how you manage. So I'm here on the TWG. I think I'll be joining you in subsequent meeting so that we can share together. Thank you, Chris. Back to you.
Okay, thank you, Mweni. That is our end division communicable diseases at NMS. So I don't know, Dr. Wachira, maybe you can share your screen. Okay, so okay, maybe he's not on the call, but let me try and call him. I can't see Dr. Wachira. Let me call him. So maybe as we allow Dr. Wachira to join the meeting, I've tried to call him, but his line busy. I can maybe I can share some.
Let me assist you, Chris. Let me assist you finding Dr. Wachira.
Okay, thank you, Doc. So meanwhile, as Mweni is helping us, I can share something. Okay, just a minute. So we can discuss these. For I know we have facility teams here who are getting challenges when they are doing summaries. Maybe I can do a quick discussion on how to do a nice case summary, like the one we have just presented from St. Vincent, as we wait for Dr. to join the meeting. So when you are doing a summary, remember you are communicating to someone who doesn't know anything about that client. So when you want to communicate to that person, you need to know what to include in your summary. So for this case, we borrowed from our team at Bagathi Hospital. So when you want to do a good summary, remember to include all the information, including the facility where the case is coming from, the MFL code. Remember to put the CCC number, because when you don't put the unique number, you might get a case from different facilities sharing same NAT number. Remember, NAT number is what we use to Dr. has joined. Okay, before Dr. joins the meeting, we can I can just do a quick one. So when you are doing a summary.
Chris,
yes.
When you're done, Dr. Wachira has joined the meeting.
Okay.
When you're done, yeah, okay.
So maybe I can take just 2 minutes to explain this. When you're doing a good summary, remember to put the weight of that client and of course the height, because you need to understand the BMI for that client. Then don't forget to put your the clinician phone number, because sometimes we get some very vital details missing and we want to confirm with the clinician. Then remember also, we mostly communicate via the emails. So you put your email and that of the facility. Then when you are doing the summary, I'm trying to scroll down. Okay. Trying to scroll this down. Okay, yeah, I got it. So remember also to put the primary reason why you're consulting. Then clinical history. This is very vital. Actually, after reading, this is like when we were in college, we were taught to make good use of HPI. This is like HPI. When you read a clinical evaluation for the client, you already know what is happening with that client before even going to the table. So you need to put the date, the HIV diagnosis, and what was the WHO staging at that time. Then you need to put the baseline investigations, especially the CD4s. Then ART regimen at the time of initiation. That is very important because it will help us understand where the patient has come from in terms of their ART. Then history of other ART regimen, if there have been drug substitution switches, or if there is a current regimen. Also, do not forget very vital aspect, and we are going to discuss it today. It's on IPT. Remember, IPT is part and parcel of HIV management. Then remember to include the history of opportunistic infections if the patient has had any episodes of TB, cryptococcal meningitis, PCP, herpes zoster, PPE. Don't forget to include that. Then also include the past medical and surgical history. You need to know if this patient is hypertensive, if this patient is diabetic, if this patient is epileptic, because these will have so much impact in that case. Remember, the client with diabetes, there is a possibility of drug-to-drug interaction with ARVs. Same case with anticonvulsant. Then very vital, family and socioeconomic history. Then also the current clinical complaint as per the last visit. If the patient maybe complained about maybe diarrhea which is persistent, remember to include that. Then physical examination, if you did physical examination and you noted something that will help your case, also include that. If there is history of defaulting, please include that one. It will also help us to know maybe where the problem started. Then now you can give us at least 3 viral loads from the last maybe the last 3 viral loads you have done. Then of course others are just flows smoothly. So that's what I wanted to explain to the team. So we can I can stop sharing so that Dr. Wachira can share his screen. Okay.
Thank you and good morning. Kindly make me a host so that I'm able to share my screen.
right away. You can share now.
Please confirm that it's visible.
Yes, Doc, we can see it.
Okay, thank you very much. So good morning, everyone. I don't know if you have done the initial introductions. I will go ahead and introduce myself because we have a very limited time and we have a lot to cover. So my name is Dr. Wachira Simon. I work with Center for Health Solutions under the TB Act 2 activity. We mostly support TB activities, but we also are part of the TB HIV support group. So we look at issues surrounding persons living with HIV and in relation with tuberculosis. So our session today will be an update. I know most of you are already trained on the new TB preventive therapy guidelines, the 2020 guidelines. However, we will still go ahead and do a recap of the updates as pertains the HIV, the persons living with HIV especially. Just a minute, my screen seems to have hung. Okay. So we begin with the difference between active TB and latent TB. And I think this is a very good place to begin so that everyone is aware of what we are discussing and why latent TB needs to be managed. So latent TB is a TB that is present in the body. You've been exposed to TB, but the TB bacilli are not growing. They're not dividing. As a result, because they are not dividing, the person with latent TB does not have any symptoms because the bacilli are in the body, but they are dormant. Because they are not dividing, they cannot be transmitted and they cannot advance to active TB disease. When you look at the opposite end, when you have active TB, you have been exposed to TB bacteria, yes, and it's inside the body, yes, but in this case, the bacteria is active and is actively dividing and growing in the body. Because of this dividing and growing, it causes symptoms. It can access the airways and therefore can be transmitted, and it can cause long-term complications and in some cases death if not treated. And then at the bottom, you'll see that LTBI is a positive test of TB infection without evidence of clinically active TB. So what it means for those who are not clear on that is you may be exposed to TB by being in contact with someone with infectious TB. However, when you inhale the bacteria, your body has adequate protection to prevent that bacteria from continuing to divide inside your body and therefore from causing illnesses. The question of why is LTBI management important? Over 2 billion people globally are infected with LTBI currently. That is the 2020 estimates that we have. That's around 20% of the people that we're estimating are coming up with active TB. Now, significantly, for people living with HIV, they are 20 to 30 times more likely to develop active TB when they're exposed to TB than for those with an intact immune system. Therefore, it is important to manage latent TB infections. And then for household contacts, if you're living with someone with pulmonary bacteriologically confirmed TB, you are at a higher risk of developing TB than the general population. And especially if in that household, there are children under 5 years of age, because under 5 years, your immunity is not yet up to scratch, and therefore you're not able to mount a sufficient immune response to prevent progression from TB infection to TB disease. So after the introduction, now what is the rationale? Why do we want to give TB preventive therapy? So TPT reduces the risk of progression from latent TB to active disease by killing the dormant mycobacterium. And here we're using simple terms. It's a bit more complicated than that, but the bottom line is TPT will address the dormant bacteria that are left in your body after you've been exposed to TB. These dormant bacteria, especially in persons with weak immune systems, can remain even after treatment of active TB. And therefore, it is still important to give TB preventive therapy to persons living with HIV after you treat for TB. We will address that going forward. Because of what TPT does, it reduces morbidity and therefore reduces progression from latent to active disease, and therefore also reduces transmission. So we are looking at TPT as a multi-pronged approach where we are reducing the number of people who are developing active TB every year by addressing the pool. Remember, when you have latent TB, you are the pool that is more likely to develop active TB, because most people do not get exposed to TB, then they move to active TB disease. When they're exposed, they usually go to latent TB phase, then they move to active TB years later. So when we address the latent TB, we will be reducing the pool of possible persons coming down with active TB. It also reduces transmission. So we are reducing morbidity through that way and reduces the poorer outcomes, because when you handle latent TB, you are less likely to develop active TB. Therefore, you are less likely to develop the adverse outcomes of TB disease. Cost saving for TB programs nationally and globally. When you are treating latent TB, you're using one drug because your bacilli are dormant and therefore they don't need multi-drug therapy. However, when you're treating active TB, you will use multiple drugs and therefore the cost will go up. This is a consideration of TB programs. And then when you're treating latent TB, there is a reduced chance of development of drug resistance. And the reason is drug resistance occurs when mutants are expressed during the cell cycle. When the cell is dividing, then that is when mutants can come up. So when you're treating latent TB, the risk of you developing drug resistance is a lot less than when you're treating active TB. So these are all the rationale for TB preventive therapy. The chart that's currently displayed is further rationale for TB preventive therapy. We are in the end TB era where we are hoping to reduce TB infections by over 90% by 2035. We want to reduce those who die due to TB by over 90%, and we want 0% of our TB patients to have to suffer catastrophic costs of seeking care for TB. So under the end TB strategy, to be able to achieve those targets that I've mentioned, there are some modeling that has been done. And the modeling is as the chart on your left. So the chart is showing the desired decline in TB incidence rates to reach those targets. And the first line in red up there is the current projected trend based on data from 2015 to 2017. So from that period, we projected that if we continue with what we were doing, then by 2035, we would only have achieved a reduction of around 15%. And that is much, much less than the target is. So the question was, what can you do to increase the rate of decline? And the first thing was by 2020, we were to optimize the use of current tools and other tools that are emerging in the pipeline. And that is why you see that the TB program is moving to introduction of TB-LAM for testing of TB. We are moving to use of IGRA and TST for testing of latent TB. We are moving to the use of TrueNut and other molecular technologies to ease diagnosis of TB. And we are decentralizing culture services. When you do that, then you see that the projected trend is likely to increase by an additional 10% per year by 20%, by 2025. To make this even more impactful, then the recommendation for Kenya was we need to have new tools for diagnosis. We need to have vaccines in place, new drugs. And that's why you see drugs like bedaquiline, delamide, rifampicin. We are getting a lot of new drugs in the TB world now. We are also supposed to look at handling of latent TB infection to remove the pool that is likely to increase the positivity rate year on year. And by doing all those, we are projecting that we are likely to get closer to the target. We will not be there, but we'll be closer to the end TB target. The TB preventive therapy is aimed at achieving the global targets to end TB by 2035. So who is eligible for TPT? As part of improving the coverage of TPT, one of the recommendations is to expand the populations for TPT. Previously in Kenya, we've been handling under 5 who are contacts of bacteriologically confirmed TB. We were handling persons living with HIV using isoniazid preventive therapy. And we're also handling prisoners and staff working in, prisoners previously. In the current guideline, the eligible populations have been expanded, and we will see why they were expanded. I don't like just telling you they were expanded. It's important for you to understand why we are now saying that persons living with HIV, both children, adults, and adolescents are eligible. Prisoners and staff working in prison settings are eligible for TPT. Healthcare workers and other staff in healthcare settings are also eligible for TPT, although that is a very contentious area, but we will discuss it. All household contacts. We are moving away from under 5 household contacts. We are now looking at all household contacts of bacteriologically confirmed pulmonary TB are covered under these populations. And then we have some special groups, clinical risk groups. And these will include patients receiving immunosuppressants, like patients on cancer chemotherapy, patients receiving dialysis, those on transplant lists, and patients with silicosis, which affects the immunity. So those are the eligible populations for TB preventive therapy. We will go into some specifics. So why have we looked at these people? When you look at, we talked about the risk of progression from latent TB to active TB. In the general population, it is between 5 and 10% that will progress from latent to active disease. However, in children, this risk increases by 3-fold. So while you would get 5 to 10%, in children, it is much, much higher than that. And those under 5 years are at an increased risk of getting TB disease from latent infection. For close contacts, those living in close contact with a bacteriologically confirmed case who are not necessarily children, they have up to a 46% fold increase in risk of progression from latent TB to active TB. And this is where we are increasing the eligible populations from only the under 5s who are contacts to the entire household who are contacts of pulmonary TB bacteriologically confirmed. Then people living with HIV have almost double the risk of progression to active disease. And the immunosuppressed, the other categories that we listed, have up to a 3-fold increase of risk. So for PLHIVs, HIV is the strongest risk factors associated with active TB disease. Up to 40% of persons living with HIV who are exposed to TB progress to TB disease. So for people living with HIV, it is critical that we continuously screen them for TB because we know they are a pool for new TB cases. They have a 21 times risk of TB disease compared to the HIV negative persons, and about 2% of PLHIVs get infected with TB annually. So 2% may sound like it's a small number, but during our discussion, I know you'll tell me in Nairobi, what is the prevalence of, or how many persons do we have living with HIV currently? Then you do 2% of those, and those are your potential persons with TB on an annual basis. So it's actually a very significant number. Then in this group, when they have TB, they have a higher chance of death from TB and its related complications. So the mortality is about 3 times higher than the general population, the uninfected population. And for them specifically, if you institute TB preventive therapy and you identify those with TB early enough, it reduces the risk of TB disease progression by up to 33%. So what we are saying with this slide is HIV is a significant risk factor for progression to TB disease. We know that our people living with HIV are more at risk of progression to TB and of progression of having a poor outcome. And the good news is if we do our job, then we can reduce this risk by up to 33%. So the question is, we are giving ART. Why are we still continuing to insist on TPT? And we have meta-analysis. So many studies have been reviewed and the data has been looked at and analyzed. And the outcome is that for people living with HIV, early screening is critical to find those with TB. Early diagnosis and treatment is critical to be able to reduce the risk of poor outcomes. And starting TB treatment rapidly reduces the infectiousness and transmission of TB, and it makes your patient respond better to treatment. Just a minute. Yeah, so the patient responds better to treatment. So there's a study called the Temprano study, which looked at ART, 6 months isoniazid, and both. So we gave one arm was only on ART, one arm was on ART and IPT, and one arm was on IPT alone. So when you compared the outcomes from the 3 arms, in total 2,056 participants were enrolled. One deferred at, no, not one. One category who were on deferred ART only. The second category was on deferred ART and IPT. The third one was on early ART, and the fourth was on early ART and IPT. So this study was looking to answer some questions that we had in the HIV world, where some people were proposing that because you are infected with both TB and HIV, we defer ART as we are giving you a TB treatment. There was another school of thought that wanted early initiation of ART, and there was another one that wanted early initiation of ART and IPT as well. So after 2.5 years of follow-up to look at the long-term outcomes, we found that when you use early ART and IPT, each independently reduced the risk of comorbidity. So when you use early ART alone, it reduces the risk of comorbidity with TB. When you use IPT alone, it reduces the risk of comorbidity with TB. But specifically, when you combine the two, early ART and IPT, this gave the greatest protective effect to our patients. Remember, when you initiate ART, you're reconstituting the body's immune system indirectly. And as a result, after the initial IPT period, then we're expecting that your immune system will be adequate to protect you from future TB events. So early ART and IPT has the greatest protective effect. For specifically in children aged more than 1 year and adolescents and adults with no active TB. So here the only person we have excluded is children less than 1 year. These groups should receive TPT irrespective of their immune status, irrespective of the ART status, irrespective of previous history of TB and pregnancy status. So that is the recommendation for people living with HIV above 1 year. Below 1 year, when you're less than 1 year living with HIV and you're a household contact of a person with bacteriologically confirmed pulmonary TB, and you've ruled out active TB in that child, then that child should be given TPT. Now, the significant thing here is for infants less than 1 year, we are not giving TPT liberally. We are not giving everybody, because when you are less than 1 year, you have a almost a 50% risk of progression from latent TB to active TB. And remember, we are only going to be treating latent TB with 1 or 2 medicines. And if you have active TB in that period and we give you 1 or 2 medicines, then the risk of you having drug resistance is very high. So for this group of people, this population of children less than 1 year who are co-infected with HIV and are contacts, we give TPT after we rule out TB. When there is no contact, then this child, first of all, you need to monitor until they're above 1 year, rule out TB, and then they will now be eligible for TPT thereafter. Specifically, TPT may be given immediately following successful completion of TB treatment among PLHIV. And this is an area where when we taught, we began the sensitizations of this guideline, there have been a lot of questions on that. And we have actually had studies that have shown that after treatment of active TB, and the patient is now considered negative for active TB, when you do tissue studies, lung tissue studies, you get a biopsy from the lung and you go and look at it under the microscope, you still find TB bacilli in the lung, viable TB bacilli in the lung. And these bacilli are dormant. They are no longer actively dividing. And therefore, this group, the persons living with HIV, will still benefit from TB preventive therapy even after completion of treatment of TB for 6 months. There is no need to repeat TPT except if among them, no, sorry, let me say that again. There is no need to repeat TPT amongst people with HIV except when these people become contacts of bacteriologically confirmed pulmonary TB. What we are saying is when you give TPT and ART, you will clear out the dormant bacilli and you will improve the immune system of your patient. And therefore, your patient should not be able to have any endogenous need for TB preventive therapy. However, when they're exposed to another episode of TB, it could be a different strain of TB. Then in this case, they will require TB preventive therapy as a contact of a person living with TB. If there are questions, please note them down and you'll ask me. So there are some populations that we've said we'll exclude from TPT. And we are excluding these populations simply because we don't have adequate evidence to support giving a TPT in these groups. We said we have persons on dialysis who are part of the population for TPT. However, persons with diabetes without any other indication for TPT will not be eligible for TPT. The reason is there are a lot of drug-drug interactions and the immune system is also being modified in that population. And therefore, we do not find there is a very big need for TB preventive therapy. Those who inject drugs have issues with adherence, they have issues with drug-drug interactions, and therefore it's not recommended. Those with harmful alcohol use, there is no evidence showing that they are they meet the threshold for TPT. Tobacco smokers, the homeless, and for the homeless specifically, it's because there will be a lot of programmatic issues with giving TPT in this group, especially with adherence. The malnourished are also not included in the TPT group. So those with severe malnutrition, moderate malnutrition with no active TB are not eligible for TPT. They need nutrition support, and then thereafter they can be considered. The reason is when you're malnourished, you're more likely to have the adverse drug reactions to the medicines that we are giving. And so we don't want to put you at risk of serious adverse drug reactions, especially liver toxicity, when we are only handling a latent infection. So when you do cost-benefit analysis, then there's no benefit with giving TPT in this group. And then immigrants from high TB burden countries. Remember, immigrants are not considered a very stable population. They are very mobile. You don't know when they can leave. So for programmatic reasons, immigrants were left out. Now, specifically with this group, you may be excluded, but as long as you have a criteria for the target populations that we've discussed before, if you're a person living with diabetes and you have, you're a contact of bacteriologically confirmed, then you are eligible. If you are a person with harmful alcohol use and you are a PLHIV, then what we'll do will not exclude you. We will do counseling to correct the issue of alcohol use. So it's only excluded if there are no other criteria that are pushing you to the inclusion. So after you identify the population, the next thing is we want a systematic approach to TB preventive therapy. So there's a screening algorithm that is used for identification of those with possible symptoms of TB. Because the first step for TPT is to rule out active TB in the person that you want to give TPT. So symptomatic screening should be conducted to all at-risk populations. And symptomatic screening, we'll look at the question in the next slide. Those who are asymptomatic are then to be given TPT. Those with symptoms should be offered TB diagnosis and managed appropriately as per the TB diagnostic algorithm. Remember, the cardinal symptoms differ from children and adults, and in adults, they are simpler. You have cough. Symptoms of TB are cough of any duration, night sweats, fever, and weight loss, which is unintended. In children, there are less typical presentations. So you can have a persistent cough or not. You could have fever. You could have poor feeding, weight loss, failure to thrive, fatigue, reduced playfulness or lethargy, and decreased activity. So these are the things that we need to remember, but there is an algorithm and it's not very clear, but I know you can see it because it's on your screens. So before you initiate a TPT, you first find out if the person has any of the symptoms of TB. If there are no symptoms present, then you evaluate. Now we are on the right side. We are moving to the right arm. You evaluate for contraindications of TB preventive therapy. And these contraindications are listed below as persons with active TB, persons with active hepatitis, persons with peripheral neuropathy, and chronic alcoholism. If there are no contraindications, you provide TB preventive therapy and do your follow-up as shown there. You assess for adherence, assess for active disease, assess for adverse drug reactions, and then finally you can give your outcome at the end of treatment. Now, if there is any contraindication, you defer TPT and you manage the contraindication, and then you can reevaluate at future follow-up visits for if the person is now eligible for TPT. Now, moving to the left side, when you screen for TB and there are symptoms present, now you need to refer to the TB diagnostic algorithm, which will tell you whether there is active TB. If it is there, you treat as per the protocols. If there is no active TB, evaluate for contraindications of TB preventive therapy, evaluate for other causes of the symptoms because your patient had symptoms, but you've ruled out TB, and then handle accordingly. So this is the algorithm that should be used when you're making a decision on how to progress with TB preventive therapy. I'm rushing a bit because of time, but I know you'll have questions. So for testing of LTBI, this is a very contentious area. So there's no gold standard method for diagnosing latent TB infection. However, we have two options that we're using in the country. The first one is a very old test called the tuberculin skin test, or MAN2. And the second one is a newer test based on the same principle, and it's called the interferon gamma release assay. We'll look at the differences in the next slide, but specifically, these tests require a competent immune response in order to identify persons with latent TB. And therefore, they are not very useful amongst persons living with HIV, because when your immune system is not competent, then these antigen antibody tests are usually affected by the immune system. These two tests cannot measure progression to active TB disease. So if you ever find someone diagnosed with active TB based on an IGRA, just know that there is no possible way that an IGRA can tell you this is an active TB case. There's no way a TST can tell you this is an active TB case, except in children, because in children, they usually have a primary TB disease kind of picture where you're exposed and you get latent TB, then active TB immediately. It's very important to note that these tests and chest radiography also are not mandatory and should not be a barrier for initiation of TPT. When you refer to our algorithm, the algorithm, and I'll go back slightly, the algorithm does not mention any IGRA or TST. So what it's saying is they are good to have, and it will give the clinician a lot more information. However, they do not rule out the initiation of, they do not contraindicate initiation of TB preventive therapy. And symptomatic screening for TB is the basic approach to diagnose those with active TB, not LTBI. Please disregard that. It's the basic approach to diagnose those with active TB and therefore to rule them out for TB preventive therapy. So we've said we look at the differences, and I will not read everything. I will look at IGRA because I think we know TST. TST, you inject an antigen into the dermis. It's an intradermal injection. And then there's a reaction in the body. You give it 48 to 72 hours, and then you measure the reaction by measuring the induration. There's a redness that happens. So you're measuring the diameter of that induration. Now the difference with IGRA, for IGRA, it is still an antigen antibody test. It is testing the release of interferon gamma by the TB bacteria when in a test tube. So you draw blood, you inject that blood into the reagent, which is in the test tube, and then you measure the interferon gamma using equipment in the lab. So there is usually a color change, and then they have a specialized equipment for quantifying how much is released. So these two tests always just tell you that you have been exposed to TB because it's an antigen antibody test, but they don't tell you anything about active TB because remember, you're testing it in blood. So it could be that you just have bacteria in your system and your body is showing that. So what we are saying is testing is not mandatory. Where it is available, it should be done for the sake of documentation and good clinical practice. But where it is not available, especially in the public health system, then it is not a bottleneck to giving TB preventive therapy. So after we've learned all that, what TB, latent TB infection is, who it involves, who is most affected, how it's tested, and how you approach this patient. So the next thing is, how do you treat latent TB infection? As we said, latent TB infection, we are treating dormant bacilli, and therefore we don't require multiple medicines. However, we have progress that has been made. So initially we were giving 6 months of isoniazid only. With this regimen, we found that there was a high loss to follow-up due to poor adherence. The duration was rather long, and most people perceived that they were not ill. Therefore, they did not complete the course of treatment. As a result, newer regimens have been developed with combination therapy. So we've added new medicines, and one of the medicines we've added is rifampicin. When you add rifampicin or rifampicin to isoniazid, then because they're synergistic, then you can give TB preventive therapy for a shorter period. So we've now moved from 6 months of isoniazid for everyone, and then we have 3 categories of patients who will be treated with these new regimens. So beginning with the first, for persons living with HIV, and because we're in a TB, HIV, TWG, I want to focus on that. For our patients, those who are above 15 years, that is adolescents and adults, are eligible for 3 months of rifampicin and isoniazid. So for HIV positive adolescents and adults, they're eligible for 3 HP. For children and the younger adolescents less than children and adolescents less than 15 years, that is the HIV negative ones, we are giving combination with rifampicin and isoniazid, and we will see why we are giving rifampicin for the HIV positive and rifampicin for the HIV negative. And then for the HIV positive children and adolescents less than 15 years, we are giving 6 months of isoniazid. And in this group, we are also adding pregnant ladies who cannot, and those who cannot tolerate the other regimens. So in summary, this slide keeps confusing me, but I like simplifying it like this. We are in a HIV meeting. So for our populations, our persons living with HIV, those below 15 years should be on 6 months of isoniazid, that is IPT. Those above 15 years should be on 3 months of rifampicin and isoniazid. And the other populations will be on 3 months of rifampicin and isoniazid. So when you look at the options, why have we picked this option for this group? For 3 months of RH, this is the same formulation as the child-friendly formulation. So it is already friendly to children. It's already tasty. It's already formulated in a way that it's easy to give to children. And it's only suitable for children up to 25 years. Those 25 kgs. Children who are less than 15 years but are more than 25 kgs can use the older RH, still the fixed dose combination that is in use. Because they are combinations, there's better adherence and there's also a shorter duration of treatment. So these patients tend to remain on treatment for longer or until they complete. However, they have interactions with PIs and the nevirapine-based ART. And because of that, they were excluded from the persons living with HIV category. So 3RH is only for the HIV negative because it has interactions with ART. 3HP is safe to use in persons living with HIV, even those on efavirenz and ratuximab. However, it has interactions with PIs and nevirapine-based ART. We are lucky that our patients are mostly on TLD, and studies on use with DTG so far are showing no interactions with rifampicin and isoniazid. So this 3HP is a weekly dose, so there is better adherence. As opposed to the rest which are daily doses, this is a weekly dose. However, there's no child-friendly formulation currently available. And I know the manufacturers are working on that because if we can get a child-friendly formulation, it will be very useful for this group. And finally, for IPT, still remains the regimen of choice for children and adolescents living with HIV on ART. Because of the long duration, there is usually poor adherence. So with this group, we need to be more conscious of adherence counseling. Isoniazid has a higher rate of hepatotoxicity compared to the other regimens. And a keynote is for all these regimens, pyridoxine should be co-administered as per the dosing chart that was given during the sensitizations. So we are giving medicines, and we know our medicines interact by their pharmacokinetics. So we need to know some specific drug-drug interactions that arise during the giving of TPT. When you begin with the PIs, lopinavir, ritonavir, and atazanavir, ritonavir, it interacts with rifampicin, and the interaction is the PIs. The levels of PIs are reduced significantly by rifampicin. So rifampicin and the rifamycins are enzyme inducers. So they induce the enzymes that metabolize the PIs, and therefore the drug levels of PIs in your body will reduce, and therefore you are likely to fail therapy. As a result, when you're on these PIs, you avoid co-administration of rifampicin. Your patient should not be on rifampicin, and instead they should be on IPT, 6 months of isoniazid for TB preventive therapy. The second category is hormonal contraceptives. And hormonal contraceptives with most medicines, even the anti-TB medicines, we know the rifamycins will cause the metabolism of oral contraceptives. The same interaction, it will lead to less effective contraception. So as management, you need to use non-hormonal methods or advise your patients to use barrier methods in addition to the hormonal methods that they currently have. So if your patient has an implant, please tusimwambie atoe implant. Remember, TPT will be for 3 months, but the implant is meant to last 3 years to 5 years. So management is just advice on use of barrier methods during this period when we are giving TPT. We have the anti-malarials, very significant, especially in the Western Kenya region and the coastal region. Anti-malarials, rifampicin decreases the level of the anti-malarials, and especially artesunate and the artemether. How you handle that? If your patient has malaria but you've not started TPT, you defer TPT first, treat malaria, and then you'll give TPT later. The half-life of a rifampicin is around 18 to 45 hours. So if you can defer TPT for 1 week after you give malaria treatment, then you'll be okay. Now, when your patient is already on 3-HP and they are diagnosed with malaria, we shouldn't panic. What we should do is we should hold on that week's dose of TPT, because we've said the half-life of rifampicin is not too long, the interactions will not overlap for too long. So you give your malaria treatment as you monitor your patient, and then you can reintroduce your TPT after a week. So these are the decisions that will be made. On a case-by-case basis, we can look at specific cases. For rifampicin, there's no interaction with raltegravir, there's no interaction with efavirenz and DTG, and therefore, when your patients are on those regimens, no dose adjustment is required. So before you initiate treatment, you must rule out active TB. And this is the take-home message from this CME. For the HIV, persons living with HIV, I don't like causing a lot of controversy, but I'll throw a question to you, which you'll ask yourselves individually. In your specific clinics, how is the TB screening actually done? The 4 questions that we ask in the CCC, do we actually take time to find out whether this is actually the true picture? And the reason I'm asking is, we have a lot of our persons living with HIV coming down with TB. And when they do come down with TB, they are usually at advanced levels. So they have complications even at the initiation of TB. So it means they have had TB symptoms for a while, but these symptoms have not been picked out. So screening for active TB is critical before you give TPT. Those who screen negative should be initiated on an appropriate TPT regimen, as we've said, and we must rule out signs of liver disease, especially for those on isoniazid-based regimens. So 3-HP, 3-RH, and IPT, all the 3 have a significant risk of liver toxicity. So we need to rule out yellowness of the eyes, that is jaundice, abdominal pain, which is usually right upper quadrant pain, and vomiting, nausea, the other symptoms of liver illness. Then patients who are being given TPT, we need to rule out diabetes, neuropathy, because we are giving isoniazid. When you give isoniazid and the person already has neuropathy, we are likely to make it a lot worse. Persons with active substance abuse need counseling and management, and nutrition assessment needs to be done, because those who are malnourished are likely to have poorer outcomes to TB preventive therapy. For adherence counseling, I will not go into details, but health workers should educate clients on TPT, why it's important, what the signs and symptoms of TB are, and give instructions that when the patient experiences the signs and symptoms of TB, they need to report promptly to the nearest health facility. Health workers need to educate clients on the nutritional status, ideal nutritional status, and counsel on food groups, drug and substance abuse and their management, and the side effects associated with treatment with these medicines that we're using for TB preventive therapy. It's critical to know that if our patients on IPT or TPT are not adherent, this will lead to progression to active TB. And because we will be giving them suboptimal therapy with 1 or 2 drugs only, then this is likely to lead to development of drug resistance, and especially resistance to the medicines we're using, that is rifampicin and isoniazid. So we are at risk of development of MDR. For follow-up should be done monthly. And during each clinic visit, you screen for active TB disease, assess and reinforce adherence, and assess for any adverse drug reactions and intervene. If any of our TPT patients develops TB symptoms or screens positive for TB while on TPT, we need to stop the TPT and manage the TB according to the national TB guidelines. Once we've done everything and we've gone through the whole course of treatment, the treatment outcomes have not changed. We have 4 main outcomes that we look at. We have those who will complete treatment. That is those who take the full course of TPT. There are those who will be lost to follow-up, and lost to follow-up for TPT is interruption for more than 1 month. There are those who will say they discontinued TPT, either due to adverse drug reactions, development of active TB disease, or persistent non-adherence. If a person is non-adherent for 2 or more instances, so a person starts TPT, then they interrupt treatment at some point, they come back to treatment, then they interrupt again, then that's a person that we need to not give further TPT, because the risk of development of drug resistance in that patient is very high, and we need to reduce that risk. So if you have persistent non-adherence, we give an outcome as discontinued. And anyone who dies while in the course of TPT, the outcome is death. So we don't leave it as after 6 months. When you give the outcome, you don't stop the follow-up at that point. You need to continue follow-up as per the schedule that we've given here. So for PLHIVs, at every clinic visit, you need to have symptom screening for TB. And for the HIV negative clients, at month 6 and month 12, then they need a symptom-based TB screening to look at the possibility of development of TB in the early period after giving TB preventive therapy. We know that current studies are showing that TB preventive therapy is protective from anything from 2 years up to 4.5, thereabouts. I don't know if there's any study showing more than that, but TB preventive therapy is protective for a period of time, and then ART will take up after that. So for the HIV negative, follow-up is at month 6 at the end of TPT, and at month 12, 6 months after the end of TPT, you do symptom screening. Finally, I have one case study, and I don't know how we'll do this, but just for your awareness. So we can have a case like a 46-year-old male who is homeless in the last 5 years, has excessive drug and alcohol use, but stopped 1 year ago. Chest X-ray has a left upper lobe consolidation, left hilar lymphadenopathy. Gene expert says MTB detected, rifampicin resistance not detected. And this person is newly diagnosed with HIV. So the question here is, what do we do for this patient? And he's my friend who called me today, Chris. Chris, tuko na wewe hapa?
Yes, I'm the one. So,
yes, so Chris.
Okay,
go ahead.
Okay. So for this client, this is a 46-year-old male who is homeless and history of excessive alcohol use. And you can see the gene expert has confirmed this is an MTB, but is RIF sensitive. So, and also the client is a newly diagnosed HIV positive. So what I'll do, this is a client with the diagnosis of TB with HIV. So first thing first, the recommendation is that you start the patient on ART, on TB treatment, then you defer ART for at least 2 weeks. So after that, the client will complete So you will start TB treatment, then after 2 weeks you start ART. Then after 6 weeks, after 6 months of TB treatment, then you can consider TPT for this client. Now, what TPT regimen do we start this client on? That is now after they have completed the TB treatment. I think we can start them on, okay. I think this one can benefit from, is it isoniazid? I'm not sure for the last one. Maybe you can help me on that.
Yeah, do you have anyone who is willing to help on the regimen? You're very correct, Chris, up to there.
Yes, Dr.
Yeah, go ahead.
These are 46-old male HIV, so we do rifampicin, isoniazid.
Thank you very much. So for the regimens, I said you will take a bit of time to internalize them. I took a bit of time myself, but the easiest way to remember is for persons living with HIV who are above 15 years, 3HP. Persons living with HIV below 15 years, isoniazid. That's a very easy way to remember. 3RH is for the HIV negative population. So for this patient, I agree with everything you've said. The only thing I'll correct is you start TB treatment and you initiate ART within 2 weeks. Within 2 weeks is considered early initiation of ART. That is not deferred. Deferred is when you go beyond 8 weeks of TB treatment before you initiate ART. That's when we say that is deferred ART when you're talking about TB and HIV. So in our case, it will still be early ART within 2 weeks of TB treatment initiation. So I think that was my last slide. I can see it's now 11 o'clock. We have a few chats. Okay, so I see there are no questions on chat. Gladys, thank you very much. Your answer was correct. That was 3HP. So maybe I can hand it over back to the admin for the rest of the session.
Okay, thank you so much, Dr. Wachira. That was a wonderful, timely presentation. So I will welcome members to ask their questions so that we wind up because of time. So there are some questions coming in the chat. Maybe you can respond to them, Doc. So you have one from John Wanjiru. For the last question, can the 6-month INH work for this client?